Hello and welcome to Newsclick. We have with us Professor Satyajit Rath from IISER Pune. Satyajit, we have been discussing this COVID-19 and SARS-CoV-2 for quite some time. Now, we have the figures which are now available over the last 2 days, which seems to indicate with the increase of testing, our numbers have gone up. And we are still looking at a doubling rate, at least for the major states. There are about 6 of them right now, that we have a doubling rate of between 4.5 to 5 days. Now that's a pretty steep doubling rate yet. So are we not out of the woods by any means?
Well, let's get something clear about what it means to be out of the woods. If anybody thinks that we are going to be able to avoid the epidemic altogether, or that we are going to halt it in its tracks and it will never come back, that's a fool's paradise.
At least not till we have the vaccines available, and that's about at least 12 months away still.
And there are a number of caveats to that as well. So yes. So what it means is that we have spots of local community transmission which are growing, and as responses of a fairly draconian kind in many instances go into operation, presumably one of the outcomes of those responses in policy and administration terms would be that there would be better and better physical distancing, and therefore transmission will be slower and slower. Basically, what we are looking at is transmission is occurring. Transmission is occurring in populations in India, across the world, in populations which are completely susceptible to the virus. How rapidly transmission?
When you say we are completely, those populations which is completely susceptible to the virus, basically we have no immunity to a novel coronavirus, and therefore when it started, we had no immunity to start with at all, anybody. Would that be right?
Yeah, so this is something that's been bothering me for a while. It is not inaccurate to say what you said, but my use of the double negative is because all of us have a kind of immunity to all viruses, in the sense that the body will respond to a virus.
Okay.
That's immunity.
Okay.
It's just that we don't have, most of us, none of us, have the kind of immunity to a new virus which allows us to avoid being infected pretty much completely.
Okay. Okay.
And that means that over the period that we generate that immunity, when the virus comes into us, for some period, we remain capable of transmitting the virus to somebody else. That's really the core issue in establishing efficient transmission by the virus. In a population that has never seen the virus before, virus transmission will be efficient. In a population, a significant proportion of which has seen the virus before, transmission is going to be inefficient.
Okay.
So with that proviso, yes, absolutely correct. We are globally not immune to this new virus, and therefore transmission is going to happen. No matter how much physical distancing we do, we are going to halt transmission. If at all we halt transmission, we are going to halt transmission only for a while, because inevitably we'll go back in one way or another, whether with government permission or against government rules. We will go back to our original, our lives such as they are, because livelihoods must be collected and lives must be lived. And as a consequence, the virus is not going to be dead and gone. The virus is still around. So we are going to keep having small outbreaks and containment and small outbreaks and containment. It's only when we as communities become largely virus experienced for this virus that we will come to the point where it will just be another influenza-like virus.
But at the moment, we are still very much susceptible to the virus, because even places like Wuhan, for instance, which has had a full-blown epidemic in the city, even there the number of people, including those who are now found to be infected, who are not symptomatic, even they are not more than the 4 to 5% of the population. So we are really talking about, even after infections, epidemics, and so on, a large part of the population can still be infected. So transmissions are likely to happen.
Yeah. So this connects to a sort of socio-cultural expectation of what an epidemic is. The 1918 epidemic went for months. In fact, it went into the next year.
Yes.
In fact, by some calculations, even though we call it the 1918 flu, there are likely to have been more deaths in 1990. So it took a very long time, by the timescales we are currently discussing today, it took a very long time for the 1918 flu to spread so widely throughout the world that a very, very large population, a large fraction of the population had been experienced with the virus and had recovered from it. We are talking about a virus that's been around for 4 months. And of those 4 months, 3 months we have spent, China has spent 3 months, various other countries have spent 1 month, 1.5 months, in a variety of intensive epidemic control measures. So it's completely unsurprising that only a very small population of a small fraction of the population has been, even today, exposed to the virus. That population remains susceptible to the virus. The virus is not going away, and therefore, sooner or later, through some incidental contact and exposure or another, the susceptible people will keep getting exposed over the coming months and years.
So we are talking about what I would call then a smouldering fire, so to say. Not exactly a huge conflagration, but fire burnings here and there, which will continue unless we have the kind of breakdowns we have seen in Italy, France, also now in the United States, which have Turkey, for example, which seems to have seen really, the epidemic seems to have got out of hand for some time at least.
So the answer is yes. But again, what we mean by the epidemic having gone out of hand is what would have been the normal course in 1918.
Yes, of course.
So what we are...
In fact, worse, because there was the war, which was still not over completely.
Absolutely.
And it was the end of the war itself which saw the spread of the virus at that scale.
Absolutely. So let us keep in mind, therefore, that what we seem to have done is suppressed and prolonged the natural course of this viral epidemic by this global response, even though different countries have responded at different times with different mistakes in hindsight and with different intensities. All of us have responded, and that response has led to a suppression of the normal course of the epidemic and a prolongation of the normal course of the epidemic. The really crucial question at this point to ask, especially when, like in India, we are in a lockdown that is now looking for post-lockdown strategies, is what are the strategies that will keep the epidemic level at what you call a smouldering magnitude?
I would call the smouldering level, to my understanding, is a level which the health system can actually tackle.
Absolutely.
Few people fall sick, go to the hospital, a few of them reach the intensive care unit, there is no collapse of the hospital or the intensive care unit system, so the deaths would then be low. Otherwise, as we saw in Italy, when the health system collapsed in some of the towns and northern states, or what we're seeing in New York and New Jersey and a couple of other states in the United States, the hospital system collapses because of the burden of infections, also the United Kingdom. And then, of course, the deaths are much higher. So that's that is what I would call as the level, which we will say, okay, we can live with this because we have no alternative.
I couldn't agree more. Absolutely. This is the real issue. Can we keep the magnitude of outbreaks within numerical limits that our healthcare systems can manage? And you will appreciate that as a consequence, the answer to this question will be very different depending on how good and effective your healthcare system is to begin with.
Quite true, quite true. And also the ability of the administration, in this case, the district, medical, and the administrative apparatus, to do contact tracing, identify the people who are ill, take them out of the population. And of course, what we have been saying in Newsclick, and what you have been saying to us as well, the need to expand testing so that we quickly locate people. And as we now know, up to 80% of the people can be asymptomatic and all still infect other people. So this is what the ICMR figures yesterday, for instance, said, that out of the people who have been identified as infected yesterday, 80% were people who were not symptomatic at all. So this is really then boils down to quick surveillance of the people, quick testing, relaxing the criteria that ICMR still officially has, Ministry of Health still officially has, that unless you now test people who are not symptomatic in hotspots, you're not going to be able to identify the people who are sick or infected. And that is the process now we have to follow.
So I agree. Let me make 2 points about this. One is, all emerging evidence reinforces what the initial appearance was, that for individuals, this is not a terribly dangerous virus at the individual level. If I fall sick with this virus, my chances, even at my elderly level, my chances of having no symptoms or only mild symptoms are most likely. My chances, therefore, as a member of the community, of dying as a consequence of this virus infection are not large enough for us to think about this virus with the kind of personal terror with which many people are thinking about it. This is not Ebola virus. It does not kill.
I mean, I'm smiling when you talk of the Ebola virus, because that has something like 80% death rate.
Well, even in the best of care, death rates with Ebola have been no less than 30-40%.
Exactly.
So,
even if you take the Middle East respiratory syndrome, which is
absolutely
another coronavirus,
absolutely,
that's far more dangerous than this one. It's
yes,
about 10 to 20% death.
This is not a virus that we should be worrying about for each one of ourselves. This is a virus that we should be worrying about at the community level on behalf of all of us, because we do not want those people, those few people who will get sick, simply because cases will come all together, not to get the kind of medical help that we ought to be able to give them as societies, communities, and governments.
So the death rates will not be high, but the number of deaths would still be high, to the extent of it could go up to 5 lakhs, 1 million. Those are the kind of numbers we could be looking at. And that's a conservative estimate.
So that's one point. My second point is about the issue that we were discussing earlier, that what we want to do is to reduce the intensity, the magnitude of the outbreak over a period of time such that healthcare systems are not overwhelmed. Here is the paradox that all of us must struggle to engage with, and that is, the better equipped we are to deal with hospitalized cases, the better equipped we are to do contact tracing, testing, and the rest of the support. Conversely, when we need maximal reduction, because our hospital systems are so sketchy that we cannot deal with large increases effectively, at that point, our abilities in the rest of healthcare, which means testing, contact tracing, good effective isolation and quarantine, are also going to be sketchy. And this is going to be the paradox that all states across the world are going to have to come to terms with, as societies, that all of us are going to have to come to terms with, that where there is the need for maximal reduction, because hospital facilities in large numbers are not available, that's where the ability to bring about the reduction is also going to be limited.
Now, here I'm going to actually take you on with an argument that actually, for instance, India has had a surveillance apparatus, however weak or weakened it might have become over years, which was the tuberculosis response or surveillance system. And we followed it up with polio. We also are supposed to follow it up with unusual pneumonia cases because the SARS issue was there. So supposedly we do have a surveillance system. We have ASHA workers right up to the village level. Now, if we see Kerala, they seem to have been able to do that kind of contact tracing, and the administration with the health minister and the chief minister seem to have been able to flatten the curve and control the infection level at a fairly small increase, a small steady level. But if you take Maharashtra, for instance, you see 4,000 over the same period and doubling rates of something like 4.5 to 5 days at the moment, some flattening. If you see Gujarat, right, very fast deaths indicate probably infections are much more at the community level than we are catching through testing. So it really is not a uniform picture as such, even in a country like India, which, as you say, is a sketchy health system even otherwise.
Absolutely. In fact, this is not even a disagreement. That argument is the direction I was going in, to say that therefore, if we are to break this paradox, the only way to break this paradox is through somewhat unconventional means. And those unconventional means in poor, resource-scarce communities and governments must be community-level extensive engagement. And the examples that you are giving...
Not the police lines that we have taken it on right now.
Precisely.
Community level.
The examples that you are giving, in fact, epitomize the point that I'm trying to make. And as a consequence, for us to generically implement what the broad contours of a state response the world over is a self-defeating exercise. We need to acknowledge the paradox, and we need to respond at ground level with appropriate tactics and strategies to resolve the paradox.
In fact, it is interesting you say that, because Dr. Aylward, the WHO person who went to China, he came back and said it was an all-in government and all-in people effort that contained the epidemic. So he didn't say it was a government effort. He said it was a combination of an all-in people, all-in government effort, which worked together. And that led to the epidemic being crushed in that sense. And it's interesting because the outside world has thought of China only as an all-in government and somehow only a top-down effort, which it doesn't seem to be the case.
No, and in fact, that's been true in China. It's been true in South Korea. So the point is well made. what we need to remember is that what administrative tactics and strategies might work in advanced economies and prosperous societies will not simply not work in developing and resource poor societies and communities, they might even backfire.
But I have again to ask you this. You were talking about the weak states, for example, and this is really large part of the developing world. But those which are resource rich seem to have fared very badly. And Italy has a good health system by all accounts. So has France. They have a good public health system as well. And the United States, much more insurance-based, but still supposedly one of the best health systems in the world. So why did they collapse?
Right. So on this matter, we perhaps have a disagreement because, you see, the comparison and the collapse that we are talking, that you are talking about, I don't see as that. The comparison for identifying collapses has to be with what I keep going back to as the 1918 flu.
Okay.
Did these communities come together and respond to a massive initial expansion of the infection through their communities? And the answer is yes, they've done so incredibly rapidly. Let me pose for you the counterfactual for us to think about. If in India, there had been a sufficiently large volume of international travel at that point so as to generate very large numbers of potential local transmission points, we would have had explosive community transmission. So let us ask the counterfactual this way. If we had had the kind of early expansions that European or North American communities have had, would we have been able to contain them as rapidly as, and I don't simply mean the state of New York, I mean even Spain or France?
Well, since we are into different territory, let's take Thailand, extremely well connected to China, with a huge amount of international travel as well, predicted to be the emerging hotspot after China. Didn't so happen. So I'm saying there are other factors at work, and I'm not going to give you that, let's agree to disagree on that point, that what is collapse as 1918 and what I would say is collapse when the health system has to triage and decide that, okay, anybody above 70 can't be saved. Let's reserve the ventilators for the younger people. I would think there is a collapse, partial collapse of the hospital system at that point. But leaving that difference aside, and you're right, it certainly wasn't 1918 by any long shot. So leaving that aside, there is another paradox of the data itself, that actually large parts of, again, Eastern Europe, large parts of East Asia, including Southeast Asia, as well as South Asia, one can argue that it's an accident that they are following behind. The issues will become the same even here also. And yes, the cases are rising rapidly, but it seems to be the transmission is relatively lower due to various reasons, and we still don't know why.
Well, it's not surprising because transmission efficiencies for a given virus, transmission efficiency, all said and done, is a quantitative measurement. It will be affected by all sorts of things. It will be affected quite possibly by weather conditions, not simply temperature, by all sorts of components of weather conditions. It will be affected by socio-cultural practices such as crowding, lack thereof. It will be affected by, it may well be modified by prior exposure to various infections. It might be modified further by the fact that governments have responded in whatever fashion. So that transmission efficiencies will be different at different points is quite honestly not terribly surprising.
What you're saying is the nature of also epidemics, they don't move in a linear fashion.
Well, they absolutely do not move.
In fact, this is one of the things that Taleb, the black swan, the person, he's talked about. The maths of this is very different. And what you can see is one super spreader can make a huge difference in a country. For instance, the South Korean epidemic, as you remember, was started by one person infecting about 2,000 people. And of course, Italy was a consequence of one football match. So you have all kinds of very different kinds of events, which can lead to very different kinds of short-term or medium-term explosions or explosive growth. And honestly, India is not as densely connected in terms of movement, etc., for example, with China is, or the European Union is. That's also true. Yeah. Our internal transport networks don't work that intensely, so to say. So that what you are saying is the transmission across people then can also be slower and therefore likely to be localized. But of course, we also have the counter examples of very dense pockets of population in the urban areas, where of course the so-called social distancing or physical distancing, and as you pointed out earlier, the word social distancing comes really, in India's case, from a very different historical context. But the physical distancing is virtually impossible.
Yeah, absolutely.
So this is still, the jury is still out, but India's rates of new infections do not show that we are anywhere near having a handle on the epidemic as yet. So still no panic button to be pressed. But what you said, unless we really involve the community and get away from the police curfew and Section 144 approach, we are not going to go anywhere.
Let me add a final point along those lines. Have we slowed down the doubling rate, for example, as you point out? And the answer is yes. The real question that all of us, state citizens, have to think about is how drastic measures do we need to take to slow the rate of transmission down, and how sustainable, especially for our poorest, most underprivileged, most vulnerable communities, how sustainable are these drastic measures over the long period of time that it is going to take before SARS-CoV-2 and COVID-19 become just another infection.
And to add to the gloom that you've already spread, let me add this other small little statistical factor, or mathematical factor. The reproductive rate, even by the slower estimates that we are talking about, even that is still around 1.5 to 2. Particularly in the states which are, as we have pointed out earlier, Maharashtra, Delhi, Gujarat, Madhya Pradesh, UP. These are states where the effective reproductive rate is almost at the level of 2. Now, as you know, it has to come around 1 and fall below 1 before you can even say that we are reaching the end of the epidemic. And 1, it will smolder. 1 to 1.1, it will smolder. It will grow, but very slowly. But anything beyond 1.5, you're not out of the woods by any manner of means.
And this is when we are using intensive short-term measures.
And for the audience, Newsclick viewers, reproductive rate is when one person infects, say 2 persons, the reproductive rate is 2. If you infect one person infects 1.5, it's 1.5. So what it really means is that if you continuously infect, say, just another person, then you're holding steady. So at the rate of 2, your growth rates are roughly about 5 to 6, maybe days you will be doubling, and which is pretty bad. That means you're not going to be able to even hold the line, so to say. So what you're saying is that we have to change strategy from the lockdown as the only measure, and we have to go into selective measures and particularly look at involving the people. in the whole strategy. Otherwise, this measure cannot bring the epidemic under control. It can only postpone the slow growth and keep it not completely into a pandemic fire, so to say, blaze, but it still would be increasing at a certain rate. Thank you very much, Satyajit, for explaining these issues to us and not sounding just gloomy, but also providing with us hope that if we do change tack and we are able to get the government to respond in more positive ways to what people have been saying, we're not the only one, people are saying, then there is hope yet of being able to ride the pandemic out till we get a vaccine. Thank you very much.
Thank you.
This is all the time we have for now. Newsclick today. Do keep watching Newsclick and do look at our other shows and also our daily roundups.